I'd like to invite the diabetes panel up to the podium, and the panel will be led by Julia Haller.
Thank you. It's a pleasure to be here and to moderate this panel, which is going to focus on the art of translating clinical trials into clinical practice. We've just sustained a terrific, but I would argue daunting barrage of information and analysis. Processing all this information can be an almost superhuman task. Fortunately, we have a panel of superheroes here to assist us, a group that is a marvelous lineup, including not one, not two, but three Wonder Women: Susan Bressler from Baltimore, Emmy Hartnett from Salt Lake City, and Nancy Holekamp from St. Louis. From New York, the Iron Man, John D'Amico, and from Iowa City, the god of thunder and laser, the mighty Jim Fogg. Jim and Nancy, this 29-year-old male physician with type 1 diabetes for 15 years comes into your office. He's 20/20 in both eyes. His hemoglobin A1C is 7.5, and you spot this neovascularization elsewhere. What is your standard workup for this gentleman? Jim.
Well, I don't really have a standard workup. It depends on if they're seeing their primary care doctor. But in a patient that would have a lot of hemorrhages in the red or cotton wool spots, I do like to get a CBC. Make sure they don't have anemia, leukemia, low platelets, and sometimes you'll actually see that. And then if they haven't seen anybody for a while, you'd get a hemoglobin A1C, you'd probably get a urine analysis for albuminuria and probably lights. But I think if they haven't seen anybody, I would try to get them to see a private physician rather than me managing their diabetes.
Nancy, what kind of tests would you get in the office?
Well, I like this 7-field imaging, but I really like wide-field imaging. I'm sure on my clinical examination I may be missing some of the findings, and now we know that the peripheral pathology is a significant indicator of the progression of disease, and so I would get a wide-field fluorescein angiogram.
Here's the fluorescein, which is not wide field, which contributes, I think, a little bit to this, this case. There we see the neovascularization. And here's the OCT. Is it pretty routine for you to get an OCT on each and every? Yeah, everybody's getting OCTs now. Okay, so NVE, no diabetic macular edema. Susan, what's your approach to treating this patient?
So I assume that this physician is asymptomatic, that he came in 20/20 and probably wasn't noticing any vision symptoms. I think the first thing is education, a little information on how he got to this point, and without intervention, what risks he's facing: vitreous hemorrhage, traction detachment, neovascular glaucoma, diabetic macular edema. We could discuss observation for further progression to high-risk disease, or intervention now, particularly since he's in the same bin in both eyes, high risk in each eye of trouble, though he's not high risk proliferative disease. I would discuss with him the importance of regular assessments irrespective of what he selects as intervention, observation or treatment, and then the treatment choices being anti-VEGF or PRP. Given that he's asymptomatic, I'd like to keep him asymptomatic, which means I do want to avoid progression to proliferative retinopathy complications, development of diabetic macular edema, or visual field compromise. And the intervention that will increase my odds of keeping him asymptomatic would be anti-VEGF therapy. So with a fully informed discussion as to what that would require in terms of regular compliant visits, I would hope that he would opt for that therapy.
And he does. After 3 bevacizumab injections on a monthly basis, he comes back and we can't find any more neovascularization. But unfortunately, life gets too busy for his monthly injections, and 6 months later, when he comes back, he may look okay on this wide field imaging, but the fluorescein discloses diffuse areas of neovascularization here. So, Don, what do you do now with this guy, and how do you think about the next steps with him?
So while I agree with everything Susan Bressler has ever said and thought, and certainly agree that education is the key, on that initial visit, the main thing I want to do is let him understand that with proper therapy, he will see beautifully until he is a very, very old man. But without therapy, Mother Nature has a 100% chance that he will go blind. Those are his odds. And once he buys into that, it's a question of how. Initially, I would not subject this physician with a A1C of 7.5, who's already being a little rangy with good knowledge of the disease. I would bring him back for a session of PRP in each eye. Then, no matter what happens in his life, and I realize that the pro and con voted this way, you will at least have some therapy on board, and you would potentially have avoided this. So I'm an initial PRP person, and that would be my strategy.
Did anybody, you wanted to answer?
Yeah, I would just say, the thing that worries me a little bit is that his NVE is way out in the periphery. And if you just keep watching him and you lose him a little bit, if he gets a lot of traction out there, that's a relatively hard surgical case to get rid of all of the traction in the periphery versus posterior traction. And I think I agree with Dawn, if you did do some PRP, it would be fairly far peripherally, and I don't think it would affect his field. And it's just a lot. It's not way out in the periphery, but that's a lot of neo out there.
Everybody on the panel agree? He's lost his opportunity to avoid the laser at this point.
So I would lobby again for repeat education on second heart-to-heart, explaining that patients like this who didn't have macular edema, they were talking an average of 7 injections in the first year, 3 in the second year, and potentially 3 in years 3, 4, and 5 if they show up for their care. And again, stressing the importance, even with PRP, that they can't disappear. If you disappear irrespective of therapy, which type of therapy, you're increasing your odds of potential blindness. And what is our hope? Our hope is with the agents that Anat was showing at the end of her talk, with these longer acting agents or longer acting delivery systems, that will be able to pharmacologically control proliferative disease without the damaging, scarring effects of PRP, with fewer injections and fewer visits in the long term. So this is a gap until we have something more long-lasting.
Great. Let's move on to another case. And Emmy, I'd like you to speak to this 58-year-old gentleman, charming guy, lives down on the shore. He's had diabetes for a while. He has persistent diabetic macular edema despite 14 ranibizumab injections now. He can't get his hemoglobin A1C any lower than 8 to 9. And he can't get in all the time. So depending on if he comes in every 4 weeks or every 10 weeks, we see that he's had focal laser, he's had PRP, and he will either be this edematous with 20/70 vision if he comes in at 8 or 10 weeks. If we can get him in at 4 weeks, we can get it down to this level. So what are you thinking about in somebody like this, and how would you approach it?
So he has had some response to anti-VEGF, so he may still have some ischemia some way. So, but the ischemia could be from other reasons, or the lack of oxygen, let's say, to the retina. So we have to think of other medical conditions or other complications associated with diabetes. So obviously it's important to have him with a diabetic doctor, and we fortunately have a diabetes center, so we can sort of send them down the street. But the things that I think of are, of course, the ABCs, right? Hemoglobin A1C, blood pressure, and C being cholesterol or dyslipidemia. But also we want to think of things like sleep apnea, which may be an issue, sometimes chronic inflammation, vitreomacular traction. This looks like the vitreous has already been release, and renal disease, and I think I said anemia as well, where there would not be as many blood cells to bring oxygen and hemoglobin.
Nancy, how would you approach treating him?
So I think this is a very good candidate for trying a corticosteroid injection. I think that it may buy some durability. I think corticosteroids have great drying ability, and with one injection you might be pleasantly surprised, and after 14 ranibizumab injections, I think that's a reasonable choice at this point.
How would you approach the steroids, Jim?
So I prefer
Or
on
Nancy?
label.
Go ahead, Nancy, yeah.
I prefer on-label corticosteroids because I know the safety profile, I know what's predictable, I know that with one injection, if there was a pressure rise, I could manage it medically, and I don't recall, are they phakic or pseudophakic?
He's pseudophakic, but that's
So it lowers the bar even further for trying at least one corticosteroid injection.
Jim, you were about to say?
Oh, no, I just agree. This is a case like Jeff Gross showed yesterday. If you go back to the laser, I think if you lasered him more, he wouldn't like it. I mean, he's probably lost field now, so laser's off the board for me. And then I think steroids a good thing. You could either use Kenalog or Ozurdex, and if that works and it comes back, then you could use an Iluvien.
So, and in fact, we did use Kenalog, then switched to Ozurdex, and then switched him to Iluvien. And here he is with Iluvien a year later. Let's talk quickly about surgery and how we're managing cases that used to be surgical cases. Are we still doing surgery on them, and are we interweaving a pharmacologic approach? So this is a 51-year-old patient with diabetes who developed neovascularization in her right eye and was given panretinal photocoagulation. Came in a few years later with vision dropping in the right eye and this macular subhyaloid hemorrhage. Don, what's your thinking about that these days as compared to back then, and how and when are you thinking about using anti-VEGFs?
Well, Julia, as you know, this used to be considered one of the classic indications for prompt vitrectomy, but I don't really think we have good data yet in the modern era, and a trial by Shi using intravitreal anti-VEGF and gas injection showed good results. So it would depend on the severity of the situation and overall visual need, et cetera. I would certainly consider an anti-VEGF injection with observation, but if the visual need pushed me to it, I would have no hesitation about recommending a vitrectomy. So I think it's something that's now in evolution again, in flux because of new agents that we have to treat.
Nancy, how about you? When you're looking at a diabetic vitrectomy, are you routinely giving anti-VEGFs in the lead up to the surgery, or how are you titrating that?
I generally do give an anti-VEGF injection prior to the surgery just to make the surgical procedure a little bit safer for both the patient and me. It's easier to control the hemorrhaging. I try to give the injection within a week of going to the operating room. I think in this particular case, what we were seeing was maybe a small frond of NVD that with some vitreous traction at the age of 51 led to a rather small-ish subhyaloid hemorrhage. I see they already have good laser, so I'm not expecting that this case would be a disaster traction RD, but in general, I think a preoperative anti-VEGF agent is prudent.
May I say one thing?
Yes.
Please don't YAG these cases. Don't treat them with YAG laser. We've seen enough difficulty with that, so I just will say from the podium, please don't YAG these cases.
Let's get to one quick more case. Susan, this is a very tightly wound 44-year-old pharma exec who's really worried about some non-central edema she knows she's got in her right eye, and comes in clasping the Panorama study and the DRCR reprints. And when we make the mistake of getting a wide field fluorescein angiogram, she gasps in alarm. Would you treat her?
So I wouldn't. I would, again, educate as to how to decrease the likelihood of retinopathy progression from a medical standpoint and the need for regular surveillance. She doesn't fit into any trial. She wouldn't have been in Panorama. She's not a level 4753, though I would also be scared if this was my eye and my peripheral retina looked like this, and that I already had some thickening happening within 3,000 microns of the foveal center. But my antenna would go up and I would be a better girl about my blood pressure and my blood sugars, and I'd show up for my visits, and the minute I got to center-involved DME with some degree of vision impairment, then I might be begging for treatment.
Would your decision be different if her hemoglobin A1C were 14?
I would be of greater heightened concern that she's going to progress, but I wouldn't pull the trigger and say, I have the answer for you, let me give you an injection now, and then what would I say? Come back every month and get an injection every month? For how long? What are my parameters? I don't know that that would be in anybody's best interest.
Just to poll the panel, in somebody without center-involving edema who has non-proliferative diabetic retinopathy, how many people are treating those patients now? Okay. Thank you very much. I'd like to thank my marvelous panel of superheroes.